In this video, we will be revising the entire physiology for the second semester compre of first year. So basically, this will be a revision of your digestive system, renal system, endocrinology, and a little bit of immunology too. So to get started, I want to make a point clear that this is purely a revision video. You will not find detailed explanation of concepts here. What you will be finding here is analysis based important concepts, important facts based on previous examination and previous questions that were asked. So let's get started. First, what about triglycerides? What do we know about triglycerides? See, the other name of triglycerides is neutral fats. So this came as a question. Okay, the other name of triglycerides is known as neutral fats. And triglycerides are the major form in which fat is stored in our body. Okay, these 2 points are important. And now, when there is high stress, see again, I want to stress on the point that there might be jumping of concepts from one chapter to another chapter in between. Just take this as a final minute revision and go through all the concepts. So now, when a person has more stress, if he's facing more stress, that means he is going to defecate more frequently. And why is that? It is because of high secretion of mucus in the gastrointestinal tract and high secretion of serotonin. Okay, so this was also one of the questions asked, and this is the concept behind it. Frequent defecation in a stressful person is due to high mucus and high serotonin. Now, another question that confused a lot of people were, how does protein gets broken down in the stomach? Many of them put dipeptides, monopeptides, and such. That's wrong. In the stomach, first, proteins break down into peptones, polypeptides, and proteoses. These three compounds go to the small intestine, and inside the small intestine, they get broken down into dipeptides, monopeptides, and all these smaller forms. So, in the stomach, remember, proteins are broken down into peptones, polypeptides, and proteoses. This actually came as a VSA. You had to type any one of the product from the digestion of proteins in the stomach. So maybe if they ask you, you can go ahead and type peptones or proteoses in the exam or polypeptides. Okay. Now, what about gastric motility? Gastric motility is stimulated by a hormone called as motilin. Okay. And it is inhibited by hormones such as cholecystokinin, secretin, and GIP. What is GIP? GIP is gastric inhibitory peptide. So remember two factors which stimulate and which inhibit. Now, what about intestinal motility? Intestinal motility is stimulated by CCK, which is a cholecystokinin, gastrin, motilin, and serotonin. All these factors increase the intestinal motility. What inhibits it? Vasoactive intestinal peptide, VIP. That inhibits the intestinal motility. Now, what does this motility mean? Motility means it is going to propel the food along the digestive tract. So, in this case, propel the food or mix the food in the stomach. In this case, propel the food or mix the food or aid in absorption in the intestines. Now, what about fat? See, fat is going to enter the cell to get reabsorbed, right? But it cannot enter very easily. So it is going to enter the cell by converting itself into micelles. So fat will become micelles and then only it will enter the cell. Enterocyte is nothing but the cell of your intestinal system. So that is your enterocyte. So a fat to enter the enterocyte, it must be a micelle. Now glycogen. Here are these both are two important enzymes. Now glycogen to glucose. What is the enzyme required? Glycogen phosphorylase. See phosphorylase, that means this is going to get broken down with the help of phosphate. Glycogen phosphorylase. Now glucose 6 phosphate to glucose. What's the difference here? The substrate has phosphate, but the product does not have phosphate. So you have to remove this phosphate away. So glucose phosphatase, which will cut this glucose and convert this as glucose 6 phosphate and convert it as glucose. Now this only takes place in the cells of your liver, intestine, and renal tubular epithelium. Okay, that is also a fact. They can give you four options. They can put heart in one of the options, or they can put any other organ system in one option and ask if whether glucose 6 phosphate can be converted into glucose using this enzyme. So you must know it happens only in these three places. Now, what about another hormone called somatostatin? Somatostatin is going to inhibit your secretion of gastrin. And if it is going to inhibit secretion of gastrin, that means it is going to inhibit the production of HCl. So HCl production is also going to go low. So understand that concept too. Now, the hormonal part is over. What about the movement part? There are two types of basic movements in the GIT. First one is your propulsive movement, second one is your mixing movement. So propulsive movement will have your peristalsis, segmentation and those things. Your mixing will have the churning of food in your stomach and all those things. Okay, so propulsive and mixing, two types of movements. Okay, now absorption. This also was a favorite question. It got repeated in the term exams and evals as well. The amount of sodium absorbed in small intestine and large intestine. It is always greater in small intestine. Why? Because small intestine is having numerous amount of sodium hydrogen pump and sodium glucose transporters. Okay, so your small intestine is going to have high amount of sodium hydrogen pump and your sodium glucose transporter 1, and that is the reason why sodium absorption is significantly greater in your small intestine than your large intestine. Now, what about phases of gastric secretion? So, gastric secretion means the secretion of your stomach, secretion of HCl, pepsin, and all those things. Now, there are three phases, namely cephalic phase, gastric phase, and then the intestinal phase. Cephalic phase accounts for 30% of the entire secretion. Okay, gastric phase accounts for the 60% of the entire secretion. So I don't think this is gastric secretion. This is like the entire GIT secretion, which is divided into these three parts. So cephalic constitutes 30%, gastric constitutes 60%, and intestinal constitutes the least amount, which is your 10%. So remember these percentages too, they might ask. Now, what about the GI activity in general? So basically, your sympathetic system is going to decrease your GI activity, and your parasympathetic system is going to increase your GI activity. And the major neurotransmitter for parasympathetic system is your acetylcholine. For your sympathetic system, it is your epinephrine and norepinephrine. So acetylcholine is going to stimulate your GI activity. Epinephrine or norepinephrine is going to inhibit your GI activity. Now, what about your gallbladder? What is going to stimulate the contraction of your gallbladder so that your gallbladder can secrete out its content, which is the bile? That is your CCK. CCK is going to stimulate your gallbladder to release its content outside. Now, what about factors that inhibit the pyloric pump? Remember, the stomach has different parts, the cardiac, the fundus, the antrum, and the pylorus. And the body, lesser curvature, greater curvature, and all that. So, in the pylorus, there is thickening of muscles. So this thickening of muscles along with the movement of the stomach is going to act as a pump to propel food into the small intestine. And that pump will get inhibited when there is high levels of cholecystokinin, when there is secretin, and when there is gastric inhibitory peptide. Okay, pyloric pump inhibitors are these hormones. Now, what about vasodilators? Vasodilators are the things that are going to dilate the arteries. So starting from your adenosine, serotonin, bradykinin, and kallidin. All of these are your vasodilators which are going to dilate your arteries. Now, glucose transporters. This is also another concept. Glucose transporters are present in two sides of the cell. So every cell has a luminal side and every cell has a basal side. Basal side is the one that is going to face the bloodstream, whereas the luminal side is going to be part of the lumen of the GI organ. Now the luminal side is going to have transporters such as SGLT1 and GLUT5. Basal side is going to have transporters such as your GLUT2 and sodium potassium ATPase. Okay, remember this is also very important. Sodium potassium ATPase is always going to be in the basal side of your cell. Now what about the other things? Fructose. Fructose is going to travel only through facilitated diffusion. Okay, fructose always travels only through facilitated diffusion. What about GLUT2? GLUT2 is going to transport your glucose, galactose, and your fructose. SGLT1. SGLT1 is going to transport your sodium glucose together. So it is also called as a sodium glucose co-transporter. What about GLUT5? It is going to transport only your fructose. This is an important exception to remember because GLUT5 is going to only transport your fructose. And remember, GLUT5 is present in the luminal side. Whereas in the basal side, you have GLUT2 for everything. It is going to transport everything out of the cell. Now, again, important high yield facts. This was a question. What are the vitamins required more in men than women? What are the minerals that were required more in men than women? So these are the vitamins required more in men than women. B1, B2, B3, C and K. What are the minerals that are required more in men than women? K, potassium, fluorine, magnesium, manganese, and zinc. Now, again, as I said, we are going to jump concepts here and there because these are totally for the final minute revision. Now, what part of the nephron forms the filtrate? It is your renal corpuscle, which consists of your Bowman's capsule and your glomerulus together. Now, again, in the exam, there might be different options based on this. So, according to that, you can give your most appropriate option. What part of the nephron forms the filtrate? It is your renal corpuscle. What part of the nephron concentrates or dilutes your urine? It is the loop of Henle. The major function is performed by our loop of Henle. Now, there was another question in which they told that a boy had to urinate and he rushed to the bathroom. And started urinating. Okay, somewhat the question was based around this. Now, when will the boy face the urge to urinate or the girl? That will be at 300 ml of urine in your bladder. Okay, so at 300 ml, there will be an urge to urinate. Now, here's another concept which is really important. This is the safety factor concept. Safety factor to prevent edema. Okay, there are three major roles here, three major factors. First is your normal interstitial fluid hydrostatic pressure. So, as most of you know by now, interstitium is the fluid present between your cells. Okay, so the interstitial fluid hydrostatic pressure normally is minus 3 millimeters of mercury. So the safety factor against edema for this alone will be the complete opposite spectrum of it, which is your plus 3 millimeters of mercury. Now, what about the second one? Safety factor of increased lymph flow. That will be your 7 millimeters of mercury. Safety factor for wash down of interstitial proteins. That is going to be 7 millimeters of mercury. Now, some of you might think, what is this? Okay, now we are at the last moment of the time. We are not going to discuss in the details of it, but just remember these are the values for the ones I said. And when you add all these safety factors up, 3 plus 7, it is going to be 17. So the total safety factor of a tissue will be 17 millimeters of mercury. And for edema to happen, the interstitial fluid pressure should rise greater than 17 millimeters of mercury so there can be edema in the tissue. Okay, so remember safety factor and the normal. This normal value was a question, if I remember it correctly. It is minus 3 millimeters of mercury, the normal interstitial fluid hydrostatic pressure. Whereas these three values are your edema and your safety factor for all these things. Now, what about concepts like hematocrit, renal blood flow, and all those things? Hematocrit is the RBC present per volume of your blood. Okay. It is the RBC present per volume of your blood. What about renal blood flow? Renal blood flow is nothing but your renal plasma flow divided by 1 minus your hematocrit. This exact formula was asked as a question. So in the exam, they might also give some values. In the rare case, they might give you some values and they might ask you to derive the value out of it. So hematocrit is RBC by volume of blood. Now that hematocrit you can apply here, you will find the value of renal blood flow, which is renal plasma flow divided by 1 minus hematocrit. Now, after 40 years old, okay, after a person becomes older than 40 years, for every decade, for every 10 years, there will be 10% decrease in the amount of nephrons present in the kidneys. So what does that mean? That means for 10 years, every 10 years, there is going to be 10% decrease. So, for like say by 50 years of age, there's going to be 10% of decrease. 60 years of age, another 10% will go. So like that it goes. So this is per 10 years, right? It's not happening like every year. So this is a gradual decrease in nephron. So if in the exam they are going to give you an option, there is a rapid decrease in nephrons or there is a fast or frequent decrease in the amount of nephrons present in the kidney after 40 years, that is going to be false because this is gradually decreasing. Okay. Now, apart from that, what about BMR? BMR is your basal metabolic rate, which is dependent on your height, weight, age, and sex. Now, sometimes in the question, they might give race and other inappropriate answers. You just choose that as the exception. Or if they're asking the right one, choose these answers: height, weight, age, and sex. Now, what about respiratory quotient? This is a classic question that comes all the time. Remember, the respiratory quotient of carbohydrates is always 1. Okay, and the respiratory quotient of fat is always the least, which is 0.7, and protein is 0.8. So FPC, you can create whatever mnemonic you want. FPC, it just increases from F to C, 0.7, 0.8, and 1.0. Okay, This was also another question's condition for measuring your basal metabolic rate. So in the Guyton and all textbook, they've just given 6 conditions. In the exam, they might give 4 of these conditions and make a condition wrong. And they might ask you to identify which one of the following is an exception. So make sure you know all these 6 conditions, starting from no food in the past 12 hours, night of restful sleep, no strenuous activity for at least 1 hour before the test, there is no psychic and physical excitement just before the test, the room temperature or the air temperature must be between 68 degree Fahrenheit to 80 degree Fahrenheit, and no physical activity is allowed during the test. Now in the exam, they might give no strenuous activity for at least 12 hours or 6 hours. So by that you should know that option is wrong because 1 hour is the required criteria here. So you can put that as the exception. They might play with any of the following options and then ask you a question. So make sure you know all the conditions for measuring the BMR. Now GLUT transporters. I'm going to leave it up to you to remember all these GLUT transporters, but one of the favorite GLUT transporters by the examiners is the GLUT2, which is present mainly in your liver. Okay, GLUT2 is one of the favorite ones. Now again, another favorite one is your adipose tissue, GLUT4. Liver is GLUT2, adipose tissue is GLUT4. Remember those things. Now, hormones. Another classic question. Which is the hormone which has 10 amino acids and is secreted by your hypothalamus? That is your GnRH, gonadotropin releasing hormone. Okay. Now, GH, growth hormone. Don't confuse these both. This is GnRH, this is GH. Growth hormone, to function efficiently, it needs insulin and carbohydrates along with it. But at the same time, weirdly, it's going to increase insulin resistance to cell. Okay, it needs insulin to function, but it is going to increase insulin resistance to cell. That means just the presence of insulin is helping it, but it is not allowing insulin to perform its function. Okay, remember that. And obviously, GH is growth hormone, so it induces growth in kids, adults, wherever the hormone is. Now, cortisol. What does cortisol do? Cortisol simply increases the blood glucose. I mean, it's not that simple, but just for the sake of revision, cortisol increases your blood glucose levels. Now, the measurements of your pituitary gland. This was also a question. They asked which of the following is false with respect to the pituitary gland. They asked it is located in the sella turcica, the size is 1 centimeter, but the weight, they gave it as 1 to 2 grams in weight. Okay, that was a really small mistake there. So that is why that was the exception. Remember, it is 0.5 to 1 gram in weight, your pituitary gland, and its size is 1 centimeter. Okay, what about insulin? These are the 3 hormones that is affected by insulin. Insulin is going to stimulate glucokinase. Why? Because glucokinase is going to phosphorylate glucose so that glucose does not escape out of the cell. Okay, and it's going to increase the activity of phosphorylase. Sorry, it is going to decrease the activity of phosphorylase. See, obviously you don't want the phosphate cut, right? If the phosphate is cut, that means the glucose can easily escape out of the cell. So it is going to decrease the amount of phosphorylase. And finally, it is going to increase the amount of glycogen synthase, which will ask more glucose to go inside the cell and then form glycogen from it as stores, glucose stores in the body, in the liver and in the muscle tissue. Now, what about secretagogue, ACTH secretagogue? A secretagogue are hormone that is going to stimulate its secretion, which are going to help that hormone. So the secretagogues for ACTH was again a question, and the answer for that is your AVP. AVP is also known as your ADH, antidiuretic hormone, also known as your vasopressin. These are the ACTH secretagogues. Now, this was a question that came, a tricky question, AVP and aldosterone. Which of the following is going to maintain the osmolality? Which of the following is going to maintain the ECF volume? Now, if you're going to just think about aldosterone increasing sodium reabsorption, you are going to think aldosterone is going to contribute to osmolality, but that's wrong. Along with sodium, water is going to follow in huge amounts. Okay, and that is why ECF volume is primarily maintained by your aldosterone. But in the case of AVP or your ADH, if there is less ADH, then there is going to be more urination, right? That means there is going to be more increase in concentration of your plasma. So that states that AVP can alter the plasma by only eliminating or taking in more fluids. Alter the plasma osmolality. So remember, AVP is going to help in osmolality, aldosterone is going to help in ECF volume. Okay, this table is also again important. What happens during hyponatremia, which dehydration, and what is the cause of it, and what is the values here for the plasma sodium concentration, extracellular fluid volume, and the intracellular fluid volume. In this, they had asked in the exam hypernatremia and dehydration. So basically, in hypernatremia dehydration, you will have high amounts of sodium, and it's dehydration. That means less amount of extracellular fluid volume. And this is primarily seen in your diabetes insipidus, where you will also have excessive sweating. Okay, make sure you go through this table. Make sure you understand this table. There can be a question asked from this table too. Now, I have pasted this just out of Guyton. The thing to note here is if a hypertonic solution is added to ECF, what is going to happen? Hypotonic, that means its concentration is less, but it is going to increase the volume of ECF, right? It is going to increase the volume of ECF, and at the same time, it is going to decrease the osmolarity because you are adding a hypotonic solution into the ECF. Okay, remember that there can be questions like this also. If you add an hypertonic solution, it's the opposite case. Okay, now how does glucose gets absorbed? It is going to get absorbed mainly by your sodium glucose cotransporters, which we already saw, which are present in your which side of the membrane. If you can remember, it is present in your sodium glucose transporter in your luminal side of the membrane. Okay, from the lumen of the intestine, it is going to put in glucose inside the cell. Yeah, so that is active. Glucose absorption is active process through sodium glucose transporters. Remember that. This was also a question. Now, histamine. Histamine is going to act through CAMP pathway, cyclic adenosine monophosphate pathway. It is going to stimulate this pathway and to show its signals and perform its function. Now, another thing that was asked was classical pathway of the complementary system. How does it get initiated? It gets initiated when an antigen binds to an antibody, and that is a reaction, antigen-antibody reaction. So your classical pathway of complementary system gets initiated when your antigen-antibody reaction happens. Now, interleukins. This was also a major part. There are a lot of interleukins and specific functions which you have to look by yourself. But an important part here is you have to know that interleukin 4, 5, 6, all of them help in stimulating your B cells, which provides your humoral immunity. Okay, humoral immunity provided by your B cells is activated by your interleukin 4, 5, 6. Now, this was also another question which we had to find in the book, which no one expect that would come, is the concentration of lipoproteins in your plasma. That is 700 milligrams per deciliter. That is the concentration of lipoproteins in the plasma. Now, these three systems are very important. These are the three systems that provide energy. Okay. First system is called your phosphogen energy system, which is constituted by your phosphocreatine and your ATP. This is going to provide energy for 8 to 10 seconds. That means for sprinters and all those people like Usain Bolt, this energy will be required most. It's going to give bursts of energy, your phosphocreatine and ATP. But if you're going to take more like marathons, that is going to be helpful by your aerobic system. It is going to provide energy for unlimited time. Now, what about in between? That is your glycogen lactic acid system, which will provide energy for 1.3 to 1.6 minutes. So the final source of energy is your aerobic system, which is going to give energy for an unlimited time. And the burst of energy is given by your phosphogen energy system, which is made up of phosphocreatine and your ATP. Okay, again back to immunity. As I said, we'll be jumping here and there between concepts. CD4 cells are the ones that will become your T helper cells. CD8 cells are the ones that will become your cytotoxic cells. These are classical concepts that everyone must know. CD4, T helper, CD8, cytotoxic. Maybe to help you understand this, you can just remember it like this: 4, and then it's like T here itself. So T helper cells is by your CD4, CD8 is your cytotoxic. Actually, cytotoxic is also T cells, but since I've written here like that, so it will be easy for you to understand. CD4 is your T helper cells, and then CD8 is your cytotoxic cells. Now we are entering the renal part. Till now was immunology and GAT. Now we are entering the renal part. Nephron. Nephron has a part, as all of you know, called loop of Henle, and this loop of Henle is a significant part of the nephron that is going to produce urea compared to the other parts. So majority of the urea secreted by the nephron is from your loop of Henle. This is also an important high yield fact to remember. Now what about neurons, types of neurons? There are juxtamedullary neurons and cortical nephrons. Sorry, we are talking about nephrons here, correct me. So cortical nephrons are the ones that are present in the cortex of the kidney, in these parts, not in the medulla. So these cortical nephrons are at the cortex, and the glomeruli of these cortical nephrons are present here, the tuft of glomeruli, and they really have a short loop of Henle. They don't go much into the medulla. Okay, so they have a short loop of Henle and they penetrate short distance into the medulla. Whereas if you take juxtaglomerular nephrons inside, they are going to have long they're going to have vasa recta too to maintain the medullary interstitium, and they're going to have long loops of Henle and more better function. But cortical nephrons, these facts, just remember that. Okay. Now what about concentration of urine? As I said before, concentration and dilution of urine, basically majority takes place in the loop of Henle. But when it comes to diluting your urine, another part of your nephron is also helping with it, which is your distal tubule and your collecting duct. So depending on how the question is asked, you got to tackle this question. You got to answer it according to that. So the dilute urine, why these both parts are involved? If you want to produce dilute urine, these both parts are not going to absorb water. As a result, more water loss along with your solutes. So that means the urine as a whole is diluted, right? So that's the function of distal tubule and collecting ducts. It is just going to stop the reabsorption of water. Now these two tables are again important. Make sure you see the filtrability of all these substances: water, sodium, glucose, inulin, myoglobin, and albumin. Filtrability is a question that can be asked. Now, this is again the same table. Phosphagen provides for 8 to 10 seconds, glycogen lactic 1.3 to 1.6, aerobic system unlimited time. Now, what about the number of moles of ATP per minute provided by each system? Phosphagen system is going to it is giving energy in short bursts, right? That means it needs to give more ATPs in a little amount of time. So that means moles of ATP is going to be high for phosphagen system per every minute because it's short burst of energy. But after 8 to 10 seconds, it's going to get over. Glycogen lactic acid system 2.5 moles of ATP, whereas aerobic system, which has to provide for long term, is only 1 ATP per minute. This is also a high yield table that you must remember. Now, what about magnesium and its metabolism? Most amount of magnesium, about 50% of the magnesium in our body is stored in the bones. Okay. Now, another fact here is daily intake of magnesium is 250 to 300 milligrams per day. And out of this intake, 50% is absorbed and 50% is excreted. Okay. And the 50% excreted is about 125 to 150, which is basically half of this. And in this, 10 to 15% is going to be excreted by your kidney in the form of urine. The remaining percent is unknown, but it's not given clearly in the book, but what we suspect is it is going to be lost in form of feces. Okay, the remaining 80 to 85, 90 to 85 to 90% is going to be lost in the form of feces. But remember, 10 to 15 only gets lost by kidneys. And 50% is absorbed, 50% is excreted as a whole. Now again, remember what are all the energy systems used in various sports. Like I said, remember the aerobic system provided energy for a long time. See, that will be helpful in marathon, cross country and such thing. See, what about phosphagen system? I told Usain Bolt, 100-meter dash for short bursts of seconds, 8 to 10 seconds. So make sure you see this table too. Now again, this is also another important table. In this table, the highlighting point is the most amount of energy expenditure is seen when you walk upstairs rapidly, which is 1100 calories per hour. Compared to all the other activities, this is the highest amount of calories, whereas sleeping is the least, 65 calories per hour. Okay, make sure you know this too because they might give you different activities and ask which activity here has the highest amount of energy expenditure. Now this illustration here is also important. Remember how much percent of the body fluid is intracellular, how much is interstitial fluid, how much is plasma. Both of these together make extracellular fluid. They might also ask you how much liters of the extracellular fluid is plasma? So you should know that is 3 and the remaining is 11, and as a whole both are 14 together, and the intracellular fluid is 28 liters as a whole. So make sure you are thorough with this too. Okay, these three tables are again important: magnesium, calcium, and then phosphate. I'm not going to read these tables one by one. Just make sure you go through it because it's pretty self-explanatory. But finish these tables because there will be questions from these tables because these three are important ions. What about clearance rate? Clearance rate is done to calculate how much is the renal plasma flow or the glomerular filtration rate. And again, a confusing question might be asked here. They might ask you in the exam that GFR is calculated through which of the substance? They might give you inulin, para-aminohippuric acid, and creatinine. The option here is inulin. That is only going to help you to calculate GFR efficiently. Renal plasma flow is going to be done using para-aminohippuric acid. Also, you can just write PAH. They can give you as PAH in the exam. So para-aminohippuric acid is going to help in the clearance of to find out the RPF, which is renal plasma flow, whereas your inulin is going to help in the finding the GFR of the nephron and the kidney as a whole. Now, again some drugs. Okay, drugs are important. Questions came from this directly. Loop diuretics, potassium sparing drugs, and thiazide drugs. First point to remember here is where do each of these drugs act? Loop diuretics is going to act on a thick ascending loop in your NKCC cotransporter. Potassium sparing drugs are going to act on your principal cells. Thiazide diuretics are going to act on your early distal tubule. And what are they going to do? Loop diuretics, obviously diuretics, right? They are going to make sure more water is lost. But, okay, wait, I'm sorry. Loop diuretics is going to inhibit the NKCC cotransporter in the thick ascending loop. Whereas in your principal cells, potassium sparing drugs are going to stimulate the principal cells to take in more potassium so that potassium is lost in less quantities. And make sure you know the examples of all these things because with examples only they are going to ask you. Okay, so again to revise, loop diuretics are going to inhibit the NKCC cotransporters, and your principal cells is the point where your potassium sparing drugs are going to act. And the example for that is lactone. Anything ending with an "-one", you can confidently put that is a potassium sparing drug. Thiazide. Thiazide is going to act in your early distal tubule by inhibiting your sodium chloride cotransporter. So the major difference you have to understand here and not get confused is loop diuretics is going to act on a thick ascending limb and inhibit your NKCC. Thiazide diuretics is going to act on your early distal tubule and inhibit your sodium chloride cotransporters. Both are different. This is sodium, potassium, and 2 chlorides, Cc. This is just sodium and chloride getting transported together. So we are almost there, 5 more slides. So another question was asked from here, low pressure vessel, which is the low pressure vessel in the kidney. So depending on the option, you just compare the pressures given here and give the answer. Now, if they're going to just end the options here, that is going to be your peritubular capillaries because peritubular capillaries have the least amount. But if they're going to go more down, then there might be a chance that you have to tick renal vein because renal vein also has less pressure. Okay, make sure you know this table too. Okay, this analysis is from the latest week for your endocrinology. Okay, uterine contractions when labor is happening is your Braxton Hicks contractions. Remember the spelling of it because this is a VSA. Braxton Hicks contraction is the contraction of the uterus during labor. Now what about human chorionic somatomammotropion? Make sure you write this whole thing if there is a VSA because in the evaluation exam I missed out writing human. I just wrote chorionic somatomammotropion. So remember it is human chorionic somatomammotropion. This was previously known as your human placental lactogen. Okay, this was also a question. And what this does is, it is going to decrease insulin sensitivity. That means it is going to decrease your glucose uptake in the mother. Okay, but at the same time, it is going to have weak actions like your growth hormone. It acts like a weak growth hormone. It is going to stimulate growth in the fetus. Now, again, another important function of this is, which was another question in the exam, was what hormone helps the conversion of ketone bodies and other substances into glucose? That hormone is your human chorionic somatomammotropic. Remember three words, make sure you don't miss human or chorionic. Now, what about surfactants? What do they do? Surfactants are going to increase the compliance of the lung, okay, and they're going to decrease the effort of inspiration. So basically, surfactants are going to make sure that you inspire at ease, and expiration is it's a passive process, right? More or less, it can be controlled. We can expire voluntarily too, but most of the times we expire air out involuntarily. So no need to worry about that. But surfactant is going to decrease the effort of inspiration and it's going to stabilize your lungs. It is going to prevent high surface tension pulmonary edema from forming. And finally, it is going to prevent epithelial and endothelial injury and also infection. These are all the points you need to know about surfactant. They might give all these options and they might change an option and might ask you which of the following is an exception of it. Now, after birth, how are these circulatory readjustments? Now, I've explained this in a detailed fashion in the chapter 84 video I made about fetal and neonatal physiology. You can refer to that. But just to summarize, before birth and after birth, your pulmonary vascular resistance is high. Whereas after birth, you have low pulmonary vascular resistance. Because the lung is inactive, it's collapsed here, right? So that means pulmonary vascular resistance is high here. Whereas before birth, your systemic vascular resistance is low. Whereas after birth, that is going to become high. So it's just the opposite. Now, what about foramen ovale? Foramen ovale is the hole present between your right and left atrium. It is present in the interatrial septum. Now, once the baby is born, how is this hole going to close? It is going to because of the changes of your right atrium and left atrial pressure. There is approximately a change of 3 to 4 millimeters of mercury, if I'm not wrong. It's around -3 to -4, I guess. So when there is that type of change, this foramen ovale is going to get closed. I'm sorry, I think I've written it the wrong way here. Let me just correct it as I'm recording the video. So foramen ovale is open before birth and after birth it's closed. I'm really sorry for that. So foramen ovale is open and then it gets closed due to the pressure changes in your right and left atrium. Okay. Now menstrual cycle. They also asked what are all the phases that coincide in the menstrual cycle. So this is the best picture to explain that. See, follicular phase is coinciding with the ovarian cycle and endometrial cycle. What are the phases that coincide? Follicular phase of ovarian cycle is coinciding with this menstrual phase and the proliferative phase. Whereas the luteal phase of ovarian cycle is coinciding with your endometrial cycle secretory phase. Okay, and on day 14, you have your ovulation, which is the ovulatory phase. Now, we are not going to the depths of menstrual cycle again because menstrual cycle is a big concept, but just these are important concepts that were asked in the exam. What about PDA? Patent ductus arteriosus. That means the ductus arteriosus, which was connecting your pulmonary trunk to your aorta, is not going to close. But it usually closes because of what reasons? That we are going to see. It usually closes because of high oxygen tension or low prostaglandins. These all factors are going to constrict the ductus arteriosus. But there is a factor in which there is less amount of bradykinin which can dilate it. But in this case, see here again to make it clear, to close it you need increased oxygen, decreased prostaglandin and release of more amounts of bradykinin. All of these are going to constrict the ductus arteriosus. But if there is going to be less amount of bradykinin, that means the vessel is still going to be open. It's not going to get closed. And there is going to be a connection between the pulmonary trunk and the aorta, which can cause problems. Okay. Now, how does this all happen? It is going to spasm or inflammate the muscle wall present in the ductus arteriosus. Okay. Remember, bradykinin, most of us might think, even I thought the same. Bradykinin is a vasodilator. I just thought that bradykinin and prostaglandins are vasodilators. But it's wrong. Bradykinin is going to decrease the radius of the lumen so that the ductus arteriosus gets closed. Okay, remember that. But prostaglandin is a vasodilator. That is why we need that in low quantities to close this. We need constriction here. We don't need prostaglandin a lot. Now, types of granulosa cells. This was not found in Guyton, but this was asked in exam, so that's why I thought putting this might be better. Three types of cells: mural, cumulus, and antral. Mural cells are the one present in the periphery of the follicle, and they're going to have lot of LH receptors on them. Okay, and they are active. Cumulus cells are the ones that are going to be shed along with the oocyte when the oocyte comes out. So you have the cumulus cells here along with the oocyte during ovulation. Antral cells are the cells that will be left behind inside the ovary itself. So let's say this is the uterus and this is the ovary. Here there are going to be few granulosa cells that will be left behind, that will be your antral cells. And these antral granulosa cells will become your large luteal cells of your corpus luteum to help secrete progesterone and estrogen. That's it. Two more slides, guys. Easy. All of these are easy concepts. Again, three layers of endometrium: zona compacta, zona spongiosa, zona basalis. The deepest one is your basalis, the most superficial one is your zona compacta. This is layers of endometrium. Remember, the uterine lining itself has three layers: perimetrium, myometrium, and endometrium. This is the subclassification of your endometrium in itself. Zona compacta is the most upper layer and it's the most dense layer. This is a very important point. And important feature about zona spongiosa, it is the layer which has the highest amount of endometrial glands. And finally, zona basalis is the one closest to your myometrium. Okay, and it gives rise to proliferative cells that will migrate towards the top later after menstruation. Now, what about corpus luteum? If you're going to remove the corpus luteum out of a mother, then that can lead to spontaneous abortion. That's a fact to remember. And again, basic questions like how much chromosomes does a fertilized ovum have? Again, remember keywords. See if the question asks pair or number of chromosome. If it is pair, a fertilized ovum will have 23 pairs. If it is only chromosome, the fertilized ovum will have 46 chromosomes. Now again, few important questions are primary hormone in secretory phase, which will be your progesterone. And then during the development of endometrium and before implantation, endometrium is going to secrete a substance called as a uterine milk, which is going to nourish your blastocyst. Okay. And finally, this is another thing to remember. The overall spermatogenesis is nothing but your primary spermatocyte becoming your four spermatids. So the key here is you have to see in the question, what do they ask? The immediate precursor of spermatids, that will be secondary spermatocyte. But if they're going to ask the entire spermatogenesis starting is about primary spermatocytes giving rise to four spermatids, that means that is true. So remember that this was also a question that was asked. And make sure you understand the diagram of the sperm and understand the mid piece of the sperm as mitochondria. The head anterior two-thirds has the acrosome and the flagellum is the tail which propels the sperm towards the ovum in the female reproductive tract. Okay, what about positive feedback? The best example for positive feedback is your LH. So basically more amount of LH is going to stimulate the brain, the pituitary to produce more amount of LH. So if you see any option that says less amount of LH in a positive feedback, then you can close your eyes and select that answer because that is completely wrong. Now, another important concept, progesterone and estrogen. Progesterone is going to decrease the contraction. Okay, it is going to decrease the contraction of the uterus, whereas estrogen is going to increase the contraction of uterus. Now tell me, during labor, what do you need the more? You need estrogen more. And that is why if you take your Guyton out now and see the graph in which progesterone and estrogen levels were high, let's say this is progesterone, this is estrogen, at the end of the graph, estrogen is going to take over progesterone because it's time for parturition. And that time you need estrogen because you need uterine contractions. And progesterone has little to give for uterine contraction, whereas estrogen has the highest amount of contractile effort in both of these hormones. Now again, if there is no progesterone, that means that can also lead to spontaneous abortion. Now what about estrogen? This is also a major difference that you must understand. Estrogen is the hormone that helps in the proliferation, differentiation and maturation of the endometrial lining. Whereas progesterone is the hormone that increases the number of glands present in the endometrial lining. Again, remember, estrogen increases proliferation, differentiation, and maturation, whereas your progesterone increases your number of glands present in the endometrial lining. Again, important concepts, sympathetic, parasympathetic, and spinal cord reflexes. Sympathetic is the one that gives rise to emission and ejaculation. Emission is the act just before ejaculation. All the fluids secreted from prostate, seminal vesicle, the sperms coming from the vas deferens, epididymis, all of them are going to come and accumulate in the internal urethra just before they get expelled out of the penis through the urethra. So that is emission. But the process of expulsion of the seminal fluid or the semen is called your ejaculation. Both of that are sympathetic, but spinal cord reflexes also help in ejaculation. Okay, so that's why there was an example in the book stating that if you cut the spinal cord above certain level, still there is going to be emission and ejaculation because they are partially both due to sympathetic and spinal cord reflex function. Whereas the erection of penis is due to parasympathetic function, which is going to vasodilate. As a result, more blood will come inside the corpora spongiosum, corpora cavernosa, and they get all bulged up, and the erection happens. Now, another fact, again facts, DHEA, dehydroepiandrosterone, is the major precursor for all the androgens. Okay, DHEA is the major precursor for all the androgens. Okay, the final slide. It is about oogenesis. Most of you might have confusion in this. So always remember, primary oocyte gets arrested in prophase 1. See, again, these are high yield facts. I'm not going to explain the whole process. It's up to you to revise that. Primary oocyte first gets arrested in prophase 1. Okay, but upon reaching puberty and such events happen, they are going to go through the cycle and they will get they're going to form the secondary oocyte, and now the secondary oocyte is going to get arrested in the metaphase 2. Now this is still in the ovary. Okay, once ovulation happens in the 14th day, the ovum is going to come out, and if there's a sperm meeting the ovum, then that will stimulate the completion of metaphase 2, and the entire meiosis will be completed. So you'll have one female pronucleus and one male nucleus both combined together and form one whole zygote or a fertilized ovum. So make sure you see this too. Okay, so I think that was the end. Now, again, I want to stress on the fact that this was just a quick revision video of all the important concepts from various chapters that will come in the COMPRE. It doesn't mean that you watch this video, everything is done. No, these are the most important ones and the most important facts out of all the analysis of all the evals and term exams we had till now in the second semester. Make sure you read Guyton, make sure you read notes. I will be attaching this annotations too in the link so you can download it from Google Drive. So make sure you do it well. All the best.